It's interesting. I've been in practice 25 years now. When I first started my residency way back when, one of the crazy things that I remember seeing was all the time the attendings would say, "You're too young for a total hip. Wait till you need a total hip. I don't know what's wrong with your hip, but you don't need a total hip because you're too young." So it was sort of like this circuitous kind of thing, and patients were very frustrated, a lot of pain. And so, for years I kind of thought that too. And then about probably 15 years ago, I started kind of understanding the hip a little bit more. And this is what we hear from patients now when we tell them, wait till you need a total hip. Patients are like, no way, there's got to be something that you can figure out. And in fact, there are a lot of things that we can figure out. And so I'll kind of talk to you a little bit about what I do with the arthroscopic stuff, with the labrum and the hamstring stuff that I do as well. The confusing part about the history is it's very nonspecific, as you guys know. I mean, there's not a lot to the hip exam, unfortunately. You flex them up, you rotate them, they're painful. Almost all of them will have some pain with flexion, adduction, internal rotation, and it's still confusing because they still might have some back issues or not. So it's certainly, one of the common things, and you need to look for these types of things is, are they getting pain just getting up from a seat? That clearly isn't going to be a back problem. Same thing with shoes and socks. That's another tip-off that maybe you're dealing with a hip issue. Because I see a lot of patients, and I have some great examples of patients that have had back fusions for presumably, refractory low back pain that's radiating into their hips. And you get an x-ray of their hips, and even in the back x-ray, you can kind of see just a little shadow of their hips, and their hips are obliterated. So be very diligent in examining all your back patients for hip problems, because it's pretty pervasive. So everything is not a back strain or a groin strain. That's the other big thing that you'll hear. I'm sure you guys see this all the time. Patients will come in and say, oh yeah, I had a groin strain when I was in high school, and they told me I just pulled my groin and it was going to get better, but it never got better. A lot of these are hip labral tears, as you guys know, or worse. Sometimes they're arthritic. When you're examining them, it's like I said, it's really very, very significant differential, and you're not quite sure what you're feeling in there a lot of times. So it's really important to kind of go the extra mile. This is an interesting thing. Tom Bird, who's a pretty well-known hip arthroscopy guy, taught me this years ago. He calls it the C sign. So when patients come in, and men will typically do that maneuver, they'll grab both sides of their hip and they'll say it hurts in here somewhere. Whereas women, because their hands are smaller, they'll typically go, it's in here. And then a lot of times they'll be off lateral, So how many of you guys have seen people get injections for Teurac Bursitis for years and years and years, when in fact there's some more significant pathology going on, not only maybe back, but probably some intra-articular stuff that's really radiating out laterally. So there are kind of three areas that you need to look for intra-articular hip pathology, and it's in the front, it can be in the side, but it certainly can be in the back. A lot of the sciatic stuff, a lot of the hamstring stuff, it's all posterior, and it's confusing because patients then invariably get referred to a back guy, and they'll, we all know that if you get an MRI on anybody that's probably over 45, their MRI is going to be abnormal, and then they'll get chased down that path and have a bunch of epidurals and probably still not get better. So this is kind of like a 2-second exam for the hip, and so one of the things that you want to do is flex them, make sure that they're supine and also sitting, flex them and bring their hip across the front. So you're trying to basically trap any kind of peripheral labral tear. This is another one that a lot of patients experience, especially some of the older women will have posterior labral tears as a result of some of the posterior osteophytes that they develop. So if you put them in that lateral decubitus position and extend them, you'll typically get a little bit of an ouch from them. And this one I call almost the Lockman of the hip. So you can kind of test for ligamentous laxity, and what I like to do is you do that on both sides. So you do the presumably normal side, see what their endpoint is, see what their external rotation is with that just slight flexion, and then try to do that on the other side and see what kind of symmetry there is or isn't. Oh, we're going the other? Okay. There it is. The other thing that drives me crazy is, and you guys need to help me here. is make sure the patients get an x-ray first. I would say probably a good third of the patients that I see in the office that really need a total hip have gotten sometimes 2 and 3 MRIs, and they've got a labral tear, but then when I look at their MRI, there's all these cysts and there's clearly no joint space, but they've gotten even a repeat MRI to see what's going on, and they've never had an x-ray. So we still, even though it's probably 1800s technology, it's still very useful to figure out sort of the stepping point for what are we going to do with this patient. If there's significant arthritis, then that's going to totally change the game in terms of the options that we're going to offer them. Whereas if it's a clean hip like this, then we can talk about arthroscopic procedures and minimally invasive procedures short of a total hip that may be useful. So it's really important. And patients still, they get mad all the time. My MA has to fight with them sometimes to get an x-ray. You've never gotten an x-ray. I got an MRI. I'm not going to get an x-ray. So it's a complete fight to understand that you really can get a lot of information. One of the things that, and not to bore you with details, but there are a lot of different angles. Like I've kind of trained myself now when I look at these to kind of look at a certain group of angles. Like a lot of the younger women in particular will have dysplasia, which really puts us in a much worse category in terms of outcomes when we do labral repairs and hip labral repairs and capsular imbrications and things like that. And then there's also a lot of cam lesions that we see, and I'll show you some videos of that just to kind of explain it. And then obviously MRI is very useful. A lot of times the most useful way to really get the most bang for the buck, and patients will ask you guys about this too, is should I get the arthrogram or not? And I think most of the time the most information is going to be gained from getting an MRI arthrogram. If they don't do the arthrogram portion, a lot of the places, especially here in LA, the resolution just isn't very good. And if you don't have contrast in the joint, it'll be sort of questionable, like, yeah, maybe there's a tear, maybe there isn't. So the most information, about 95% of the time, if there's a labral tear, the arthrogram is really what's going to help at least see it and sort of manage what we're going to do. And then, as you guys know, the anatomy is complex, and from the skin to getting down to that capsule, there are a lot of layers. There are a lot of nerves. A lot of people will have some lateral femoral cutaneous nerve irritation anterolaterally. As you guys know, a lot of these patients will come in saying that they almost have like knee pain, and they'll argue with you and they'll insist that you get an x-ray of their knee, even though you know it's probably radiating pain. So we need to look for the obturator nerve issues, some of the femoral nerve radiation, and especially the anterolateral. A lot of patients will come in with lateral femoral cutaneous, like they'll call it zingers or burners down the anterolateral thigh, and that's why I think a lot of times they end up getting referred to the spine guys, but in fact the problem is really just a local hip problem that needs to be addressed. So how do we figure out what's going on? What's in the box? One of the things that I started using ultrasound in the office probably about 7 or 8 years ago, and it's just great, the ability that we have to see things. And this is kind of cool. We can actually take multiple images and stitch them together and get a good view of the entire thigh if we need to see, like the abductors, for example. Like GM there is the gluteus medius and the star is the greater trochanter. So we can get a really beautiful view of the entire anatomy laterally. And this is how I do it in the office. So it's a really simple procedure. If we're looking for a muscle tear or if we're looking for bone spurs, a lot of times we can see it with the ultrasound. Here's an example of how quick an ultrasound guided injection is in the office. So you can see the patient is just laying there. I have the ultrasound device. It's basically a laptop. If you guys haven't seen it, it's really amazing. We just roll it into the room. And my nurse has already prepped the area with DuraPrep. And so we just put the probe on, and then I'll show you the quick, easy. So FH is femoral head, and then the anterior capsule is the little arrows there, and you can see the injection going right into the hip joint. So in the old days, we used to have to take the patient to the surgery center, get them under sedation, do these procedures. It was a big hassle. It took hours for the patient to get in and out. Now I can do it in 2 minutes in the office, and it's a guaranteed injection. You know exactly where the injection went. Is it in the bursa? Is it in the joint? Or if it's piriformis? So depending on where it is, we can really kind of look all the way around 360 degrees around the hip with ultrasound. And then the other thing, which I'm sure you guys have heard about, is PRP, and a lot of you have a lot of knowledge about PRP and see your patients get it all the time. So I kind of use the PRP. We use it in conjunction with ultrasound because it allows us to really deliver the injections exactly where we want. And as you guys know, the PRP is just a concentrated factors essentially. And so the autologous growth factors and proteins enhance the healing capacity. And I kind of use it judiciously. Some guys out there are maybe doing a little bit more than they probably should. I think I like to use it in younger patients. I think it makes sense. I think for muscle injuries, for sure, it's a great option to try. Like I see a lot of hamstring partial tears. I think that's a great option. I haven't been as impressed for mechanical symptomatology. Like if you've got a big labral tear, I think maybe it's worth it in a younger patient. Certainly some of the older patients still want to try it too, and it's reasonable. It doesn't burn any bridges, but I just haven't seen as good a result in those groups. Sometimes patients do it themselves. This is an example. This is a great example of somebody that really did well. He's actually a NFL kicker, and he had strained or almost partially tore his rectus, but it wasn't quite surgical, and he was mid-season, so he wanted to try to get back. And you can kind of see on the arrow there's huge hematoma, and you can see it here in the office. The rectus was just completely swollen. All of this is just blood and swelling in the rectus musculature. And so what we can do is, in the office, where we prepared the PRP, and you can see here in a second, I'm going to come in and give them a little lidocaine peripherally, and you'll see how the area kind of lights up here in a second as I put the needle in with the local lidocaine to make the procedure just slightly more comfortable, because it does irritate, it burns a little bit as it goes in because it's fairly acidic. So that's the muscle sheath that we're seeing the outline of. And then in the next step, I just go in there and just inject the PRP directly into the musculature. And he was able to get back within 3 weeks, which is pretty significant. And I think in the old days, I think it would have taken a lot longer for this guy to recover. So we actually did him 2 weeks in a row. We did some PRP 2 weeks in a row in order to try to expedite his recovery. A lot of the younger people will have, younger women in particular, you'll see snapping hip, like psoas tendon. This is a great opportunity with the ultrasound to just do a quick diagnostic injection immediately, like right into the psoas tendon sheath, and avoid the joint altogether. So if they get good relief, you know it's their psoas and it's not the other parts of the hip. Trochanteric bursitis, again, this is the area here, right in there is where the bursa is completely full of fluid, so we can really help identify the area exactly. A lot of times it's a bit of a guess. If you don't have ultrasound, you just sort of poke around and stick the needle in a couple different places. But with the ultrasound, we can really make it a truly surgical sort of procedure. Here's an example of a lateral snapping hip. This is a young boy. You can kind of see it at the end there as he brings his leg. I had the probe and I was trying to hold it, and you can see that snap there, so you can kind of document that it's not, because patients will come in and tell you, my hip's coming out of place, and then you try to convince them that it's not really coming out of place. So I showed in this situation, the kid and the mom as well, that the hip really wasn't coming out of place, just a snapping hip. And then the final area is around the back is the hamstring. So we can identify, so that's the greater trochanter. The patient's laying on her side, so that's the hip that's sticking up, and then we find the ischium. So I kind of go immediately posterior to where the gluteus maximus is. We can identify the ischial hamstring origin and then put the needle right into that bursa. And again, get a good diagnostic injection that we know is exactly where it needs to be. Similar procedure can be done for piriformis tendons. And I've done a handful of those too with PRP and with cortisone and different mixtures. And then obviously if all of these relatively non-invasive things work, then we can go to surgery, and it's changed quite a bit from the medieval days. The arthroscopic, this is from a little video that I did a few years ago where we came up with a process for examining the hips. We came up with this 23-point exam that's been published in a lot of different articles, but basically it's very algorithmic method where we go into the hip and we're going to look at points 1 through 7 from the one portal, points 7 through 14 through the other portal, and make sure that we kind of cover all the bases on these patients that often are young athletes that we need to really make sure and get the right diagnosis on them. Here's, this is the setup. So the arthroscopic procedure, so I'm standing there operating on the patient, and then the C-arm comes in. So we always have x-ray guidance as well as diagnostic guidance with the arthroscope. So it's a very exacting procedure. A lot of times, I don't know if you guys have seen, some of you guys have seen arthroscopic surgery, but we'll actually have the hip in traction and move it and rotate it and make sure that we can identify all the areas that are impinging or not. So these are the two big areas that you guys have heard a lot about with respect to hip arthroscopic procedures. The CAM procedures where we reshape that bump. And so you saw as, I'm gonna go back to it. So you can kind of see here that the video is sort of depicting what the abnormal sort of bump is. And what happens is with flexion and rotation, you can kind of see how it starts to slide into the acetabular subchondral area, and then it really, a lot of these patients, and I've seen some really bad injuries in kids that are 20 and 25 years old with significant chondral articular damage as a result of that. So that's one area, and I'll show you a quick video too how I address that surgically. And then the other one is the pincer, and pincer, the difference is pincer is an overgrowth of the acetabular side. And as this thing is depicting, it's a little bit different pathology. So a lot of these patients will typically have more of a really destroyed labrum. It's not so much articular cartilage problems as destroyed labrum. So these often patients are often really the ones that we try to do labral reconstructions on as opposed to a labral repair, because by the time they come in to see us, their labrum is literally shredded. So there really isn't any good healthy tissue, as opposed to the CAM patients that oftentimes it's really just deal with the articular cartilage damage that they might have, and then go ahead and do a labral repair, and they do well. So it really depends on exactly what their pathology is. A huge difference in outcomes. And some of these patients also have these AIS overgrowths, and the one at the top there, you can kind of see how that piece is sort of jutting out. That kid had a fracture when he was younger, and it grew like that. Sometimes it's more of an anatomical variant like the one on the left, on the far left. Just to kind of show you this, I've already passed the suture around the labral tissue, and then this is an anchor, and it looks huge, but it's actually only 2.1 millimeters in size. And most of the materials that we use now are either PEEK, which is a plastic material, or sometimes we'll use bioabsorbable composites. This one is a PEEK anchor. And you can see, so we'll drill the hole, prepare the labral tissue with the suture, and then it's a pretty simple matter of just sort of tensioning it and getting it just right. And you can kind of see now how it brings it back, and it's still a little bit rough, and obviously the body will kind of take care of smoothing that out. And here's the other anchor. So this one is now being inserted from the anterior portal. So the same anchor, it's a knotless anchor, which makes it really simple, and there's a lot less prominence of soft tissues. And then once we put the femoral head back in place, then we can see that we now have a really nice labral seal. And this is the area where we've done the femoral neck resection now. And I'll show you just a quick example of the, on that patient, by the way, is this kid. And 9 months, so 9 months post-op, he was able to go back to kicking at a Division I level, which is really impressive. So this kid was a 20-year-old collegiate Division I water polo player. And so he had this huge CAM lesion, and you can see that's all articular cartilage damage. So you can see that whole area up there is down to bone. So he's got a pretty significant area that I had to do a chondroplasty on. And then this is his CAM lesion. You can kind of see it. There's no part of that head that looks normal. It looks like a big knob that doesn't really fit. So it's the proverbial square peg in a round hole. And so these are sort of the tough ones in how to deal. You can kind of see how it's coming out at us. So that entire thing should not be there. So I use x-ray guidance typically to kind of start the process. So we kind of draw a line across the front, just sort of preliminarily. And then you'll see in a second here, I just kind of slowly sort of start connecting the dots and start reshaping the whole thing in a piecemeal way. You can't really just take out the whole thing. So you can see that now this is kind of halfway through, and you can see how much bone I've actually taken away in this case. And in this situation, it's almost like a third of his femoral head was sort of abnormally sort of overgrown. So you can see at the very top, that's the part of the articular cartilage that's remaining, and then now that's the final, the sort of finished product. And one of the things that we always want to look for here is to go around to the back and make sure that their vasculature is intact, because if you're too aggressive, you can take out some of the vasculature to the femoral head and they can get AVN, so you definitely want to avoid that area. So here's another example. This was also a collegiate, he was a runner, and you can kind of see the cam lesion there laterally, and then that's what his the resection area looks like, and then that's what his radiograph looks like now. So we can do quite a bit, and part of what I didn't show there is we're actually moving the leg and just making sure that we can kind of get 360 degrees around the hip and make sure that we can fix everything. Hamstring injuries is probably the last thing that I've gotten into in the last probably 7 or 8 years, and so we do the patient in the prone position, and we do it through 3 or 4 small incisions as opposed to the big historical incisions that you guys have seen. That's the sciatic nerve right there, so I'm exposing the hamstring tear. This is sciatic nerve that we're looking at right there, and I'm kind of dissecting the nerve away. And so the nice thing about when we're doing it endoscopically is we actually get this magnification. When we do it open, there's a lot of blood, it's really difficult to see the planes, and I find that the endoscopic way to do it is much, much nicer. So these, I kind of joke around with a couple of my shoulder partners, because if you turn this video sideways, it looks just like a rotator cuff repair, if you guys have seen the video. So it essentially turns into a rotator cuff repair. So we're able to put the anchors into the ischium, and then you'll see I start passing the sutures, and I basically just borrow Dr. Snyder's, shoulder arthroscopy set. And you guys have seen some of these videos in different presentations over the years. And we can end up with a pretty nice repair in a minimally invasive fashion. And the nice thing about when we do these partials like this is I'm able to have them fully, like foot flat weight bearing at 48 hours. So we're really getting pretty aggressive with the rehabilitation. The old days when we used to put them in a hinged knee brace or an HKAFO are gone, because a lot of them I actually had, part of what prompted me to push this was I had a couple of really young patients have DVTs for no apparent reason other than just the surgery. So it's a really hard thing to sort of justify. If you get a DVT from a a large procedure, it's different, but for these it's really nice. So that's kind of what the final, you can see the sciatic nerve is sitting right next to where we're working the whole time. So I'm visualizing it and making sure that we're not putting any stitches around it or through that area, and you can see we can bring it really nicely. Nerves completely protected, and there's no injury to it. So the final thing I want to talk a little bit about is, do you want a hip replacement with that kind of incision or that kind of incision? Pretty straightforward, right? So this minimally invasive anterior stuff has been a godsend, I think, for total hips, and there's a couple total hip patients here I know already. So any of these sort of minimally invasive approaches are dramatically better than the historical things that we used to do. And we can put these things in, even though the devices are actually pretty big, if you do the incision in the right place, you can get it in there. Here's an example. This is a step-by-step roughly of one of my patients that we did a few weeks ago. As you can see, one of the cool things that we have now is a lot of the computer-guided software that allows us to really put the devices in the right angle. More importantly, which is a source of frustration for patients, is if their leg lengths aren't equal. So with this computer-guided software, I can match their leg lengths within probably 3 to 4 millimeters, which is pretty good compared to what we were able to do historically years ago. You can see here's the incision at the top, and then again we're using radiographic guidance. One of the areas, acetabular cup positioning historically has been a bit of an issue. With this software, it's really not much of an issue, because you're going for 45 degrees of inclination, 20 degrees of anteversion, and if the computer tells you that it's not there, you can just keep positioning it until you hit it in the right place. And then here we are at the bottom, we're checking leg lengths at the end once we've got the components implanted, and we make sure that we've got the right tool. this one I actually want you to hear. This is the little jackhammer that we have now. And you can see on the video at the top where it's actually, basically I just position it, and this thing, I don't have to use a mallet or anything. It actually forces the device into position, in the appropriate position. And we use it on the femoral side as well, too. So it's really amazing. Here's an example of a patient. Obviously, I'm going to show you a good patient. I'm not going to show you somebody that's still on a cane or a crutch or anything. But this guy is actually an actor, performer, martial artist. And he had been doing all kinds of crazy things with this hip. And he's only 38 years old. And so I finally convinced him that he should have a total hip after, I think I probably injected his hip 6, 7 times maybe, because he had some other movie or some other thing to get through. Here he is at 9 weeks post-op. Obviously, he's pretty happy. And then he had the audacity to send me this video. It's his left hip, by the way. So I told him to lay off. All right. Well, thank you very much, you guys. Great turnout. Really appreciate it. Woo!